Welcome to CareTalk, your summer home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix.
Hey, John, let's talk about palliative care today. And let's start with some best practices. What are the best practices in palliative care? And how do we think about that as it relates to COVID-19 patients?
Well, there's a lot in there, David. Palliative is often code for end of life, but it's really covers two different categories of holistic care, whole patient care, something that at CareCentrix we take very seriously. It's thinking about the emotional peace of mind and all of the things that can bring healing, particularly focusing on the non-clinical. That's obviously most clearly needed when there's a clear end of life and people go into hospice, which is where the point of care is not curative because the presumption is that you're already critically ill and fatally ill. But the objective is to do the best care for the patient, which is making them feel more comfortable in dealing with all of the other aspects of care. But that holistic care that's embedded in palliative is actually kind of the right way to think about care in general. It actually returns care to healthcare because we spend a tremendous amount of money at end of life trying to use interventional curative medicine when really palliative and hospice would make a lot more sense. So from a healthcare perspective, palliative really is a very different approach than the traditional curative approach. And let's hold aside COVID-19 for a second and really maybe dig a little deeper. I guess one question for you, David, as an expert in the healthcare area, why isn't palliative more common? And why do so many people fight to get access to hospice care at end of life? Because as far as we can tell, only like 20 to 30% of the people who would like hospice care get it today.
Well, John, I think going back on, sort of palliative care and why isn't it used that much, one reason is I think people associate it very, very closely with hospice care. So I think palliative, and I'm thinking, okay, it's end of life, I'm lying in bed, someone's giving me something to make me more comfortable. But really, the best practices in palliative care, it's not intended to help to speed up or postpone death, and it allows people to live as accurately, as actively as possible. So there, you could do as much as you possibly can to get the most out of your life, but that's just not the image that people have of it. It's very, very closely associated with the last days. And I think that people then, when they do get into hospice, which is for end of life, they kind of fight it until the end. They fight the idea of it because they think it means you've given up. And it's really not about giving up.
Well, and in fact, when people, of the critically ill people who do enter hospice, the average length of stay is 2 weeks. And these are often critically ill people who've known for months and months before that there was going to be an endpoint, as there will be for all of us. I think my view, David, is that the curative system driven by transactions and thinking about every patient as a bill or a cost or a potential margin opportunity doesn't easily let go of its grip of vulnerable, chronically ill patients. And certainly that's one of the reasons why CareCentrix, we bought a company called Turnkey that's really focused on palliative and end of life, scientifically looking at algorithms that are predictive around folks who are critically ill, who might need access to palliative care. But the other thing it underscores is how little the rest of the healthcare systems takes advantage of the interdisciplinary approach of hospice, which integrates social workers, pain management, doctors. It's not like you stop seeing a doctor. You just get more access to more alternative types of care.
Well, John, I think that certainly I will, I guess, endorse your cynical view that every patient looks like margin opportunity, and that's where people are going. I think it's partly what happens is the doctors are trained so hard, to fight against illness and to cure that they sometimes forget, or they put it sort of secondarily, that you're dealing with a person that's got kind of these overall broader needs. And sometimes when they're focused very much on the cure, the treatment, which is what the doctors are focused on, and they're knowledgeable about, they just don't have time to think, or they don't have the training to think about the more holistic elements of it. They don't necessarily fight it when you bring it in, but you can't expect necessarily oncologist or surgeon to be so knowledgeable about palliative care.
Well, but palliative is an approach, David. Let me just share. So I think you're absolutely right that the average doctor really cares about saving people, and that's what gets people excited. It's empowering for the doctor. It's inspiring for the patients. And we've got an amazing system. But I'll tell you that when my dad had a traumatic brain bleed, and we went to the wonderful surgeons in one of the great Boston academic teaching centers, and we asked what they recommended. They recommended dramatic, disturbingly disabling brain surgery. And it was only when we were, with a little bit of a background in healthcare, I convened a family meeting with doctors who were working the case and doctors outside, that every one of my family members decided that not going for the disabling brain surgery, which even after they discussed it, the doctors didn't really agree with, was not the right path. But if we had just let the medical industrial complex go, it would have been much more damaging to my already desperately injured dad, and it would have been devastating for the family, and it probably wouldn't have worked, and it would have cost an enormous amount of money. And I just think the system needs to think whole patient and family and what the best wishes are, and the system isn't set up to do that, both because of the courage and the confidence of the doctors. And I don't underestimate how important money is in healthcare, David. That's why we have the most expensive healthcare in the world and not necessarily the most effective.
Well, John, I know you didn't want to talk about COVID, but since you seem to be willing to talk about disabling brain surgery and family stress, let's actually jump into it, because I think COVID actually exposes the need for whole patient care and the need for palliative care on a broad scale. The whole system is kind of taken over by COVID patients. You can't actually even have the family around. You talked about having a family meeting. Good luck with that when somebody's actually hospitalized for COVID. You've also got patients who are on ventilators. They can't speak or hear. And it's been a terrible situation. And I think the people that are in the hospitals feel terrible about it. And so do the families, and so do the palliative care and hospice professionals. I mean, what do you think about it?
Well, no, you're on a really powerful point, because if you look at kind of the way CareCentrix thinks about whole patient, and we focus on patients' goals, not necessarily their clinical goals, the average chronically ill person at discharge, only 1 in 3 or 1 in 4 times actually talks about getting better. They've got other goals for their life. Think about that. 70 to 80% of the system is focused on not meeting what the actual patient's goals are. And then you have a system that then disconnects patients from their families, and often the family caregiver and the family. COVID is a devastating, it's disabling in a different way because it disconnects us. We're profoundly social beings, and when a member is critically ill, the family needs to help manage it. And I think it's been disabling there. To be fair, I think the healthcare system has done a really good job at reacting to it and trying to really provide curative care as quickly as possible for an unprecedented amount of demand. So I really don't think I'll blame the healthcare system for a lot. I just think that what we've really not gotten our arms around is how dangerous disconnection is to health. And it's true whether it's palliative and end of life and being a part of the medical industrial complex, but it's also deeply true for those lonely patients who can't even see or touch their loved ones. And I can't imagine how that feels. And also, I can't imagine that it doesn't have a burden or an impact on people's ability to heal. Because I know that you think about the emotional networks we all rely on, they're all shredded in a time of COVID.
John, I know you said you don't think I want to talk about money in healthcare, but I'm happy to. You talked about where the finances are. Now, clearly, there must be some financial incentives in the system related to palliative care. CareCentrix is a business. You're in the business of palliative and hospice. So, what are some of the key financial incentives, and are they well aligned with patient and family needs? And if not, what needs to change?
Well, I think that there's a lot to unpack in that question. The first thing is, we really focus on serving health plans and MA plans. And what you find is the current way that the benefit is sorted out, that you have to make a positive election to hospice and then you're no longer on the MA plan's books. You see some of our competitors shifting expensive chronically ill patients to hospice, and suddenly, they no longer have to pay those bills as they get larger. And that's a loophole that I think CMS is going to end by folding hospice back into Medicare Advantage, which it should. The other thing I think you see is, and there's some really interesting, exciting work being done at CMMI, the innovation group at CMS, and Senator Wyden's talking about, which is to start to do a demo around a community-based interdisciplinary palliative care benefit, where you'd integrate a team with a nurse, a social worker, a music therapist, a chaplain, massage therapist, with the pharmacist and the doctor, and really start to think about how could we imagine these non-traditional healthcare services as being part of healing our chronically ill or vulnerable elderly? And I think that for $500 per member per month, you could put together an interdisciplinary team that could really potentially have a big impact on the healthcare of our frail elderly. We may find, and I suspect we will, that the right interdisciplinary team may be a lot cheaper than the overly disciplined team of medical professionals, really help people manage their chronic illness.
Well, John, of course, when you're talking about MA as Medicare Advantage, the managed care component of Medicare, and we've talked a lot about how they've actually increased things like supplemental benefits, and in a way, you can think about palliative care and a whole patient care as being tied into that as well. So I'm hopeful that Senator Wyden and others that are working on improved access here are going to be successful.
Yeah, and the other point, just to build on something we've said about other sessions, the palliative and end of life care is really it's called a benefit for a reason, and you'll find that people of color are represented in much lower numbers, even of those who elect hospice and palliative care, and that just speaks to, again, a blind spot in our healthcare system that we've got to deal with. As we expand this, we shouldn't repeat the mistakes of the past of treating people of brown and black people and Indian people, people of color, differently than white people.
John, it's a good point, and one that we'll end on here. I think, especially as we consider doing new things, let's not repeat the mistakes of the past, but in fact, learn from them. That's it for this edition of CareTalk, where we've been talking about palliative care. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for listening.
Hey there, listeners. Want more CareTalk? There's more to be had in our other episodes, so be sure to look for those and subscribe to CareTalk on your favorite service.